Good afternoon. We are about to start. This is September 13, University of Benin Teaching Hospital from the Department of Medical Microbiology. We want to join the rest of the world today to mark the World Sepsis Day. We have done several educational awareness creation this period. So today is the day to commemorate the World Sepsis Day following the WHO. So we have a guest speaker today that will be taking us through the process of the challenges we have with diagnosis of sepsis, and how to do what we should do, and the position of prevention when it comes to sepsis management. So we are going to listen to no other person than Dr. Osaibovo. He's a consultant and a senior lecturer at University of Benin and consultant in University of Benin Teaching Hospital. So she's going to take us through the process. Before we continue, I want to say a special thank you to the ICT team of University of Benin Teaching Hospital and the management, the dynamic management of University of Benin Teaching Hospital who made all this possible. If you look at the videos we have shared around social media and the pictures, you see that everybody is proud to be associated with University of Benin Teaching Hospital. Special thanks to our Professor Daliti Obaseki, Ebo CMAC, and CMAC of the hospital, and all our management team that are present in the call this afternoon. Thank you very much as we invite our speaker, lecturer today, Dr. Osaibovo Iriagbonse, for the presentation. Thank you very much. Over to you, our guest speakers, ma'am.
Okay. Good afternoon, everybody. Thank you very much, Dr. Iguma, for the introduction. As we know, September is Sepsis Awareness Month, and today is World Sepsis Day. And that's why we are having this webinar today. I'll be sharing my screen so that we get straight into the presentation. So today, I'm presenting challenges of sepsis, diagnosis and management. And I make bold to say that prevention is better than cure. So I'll be taking the presentation using this outline. We'll be looking at the burden of sepsis, the risk factors and pathophysiology, diagnosis and management. And then I'll delve right into the challenges, prevention of sepsis before concluding. Now, sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection across all ages and pathogens. So notice the emphasis on all ages and pathogens. Sepsis is a medical emergency, and the word sepsis is derived from a Greek verb, sepo, which means I rot. So sepsis has been recognized for millennia. Despite its ancient roots, sepsis remains a challenge even in contemporary times. The frequency of sepsis is increasing, it's expensive to treat, and it can be lethal. And as frequency is increasing, it's expensive to treat, it's lethal, with an associated rate of death as high as 70%. And not just the lethality of sepsis, but even in survivors, they have long-term physical, cognitive, and psychosocial morbidities. And they have an increased mortality rate up to 2 years after a sepsis event. So you will agree with me that sepsis is indeed a very big problem. Like I mentioned before, the infection that causes sepsis cuts across all pathogens, even though it is often bacterial. Most of the times it's bacterial, but fungi, viruses, and protozoa can also trigger sepsis. Infection that causes sepsis can be bloodborne, or it can be limited to a small area. But once a septic reaction is triggered, the resulting damage is widespread extensive, and life-threatening. Now, let me talk a little bit about septic shock, which is a subset of sepsis. In septic shock, we have refractory hypotension. That is the need for vasopressor therapy to maintain a mean arterial pressure of 65 millimeter mercury or greater. We also need, in addition, there's a serum lactate level that is greater than 2 millimoles per liter that persists after fluid resuscitation. And septic shock is a very big killer in sepsis. So it's a subset of sepsis that rapidly progresses to death in most cases. Now, quantifying the burden of sepsis is a challenge. And so we have the quantification of sepsis is not very accurate. A lot of sepsis cases are unrecognized. And so that makes the burden that we have not to be exactly accurate. However, using the global burden of disease of 2017, estimates were made that showed that 48.9 million incident cases of sepsis occur every year, including 11 million deaths. And 85% of these statistics are in low and middle income countries. They are in low and middle income countries. So that shows that they are disproportionately affected. And we know that these countries are least, so I was talking about the burden of sepsis. And what I've said is that low and middle income countries are disproportionately affected. And another interesting fact is that more than half of sepsis cases occurred among children, many of them neonates. And so these two groups of, these two demographics need to be really looked into. Now, the infections that predispose to sepsis, most of them, up to 60%, they have their source in the lower respiratory tract. So lower respiratory tract infections are the commonest source of sepsis. This is followed by intra-abdominal infections. The urinary tract is also common, especially in the elderly. Now, interestingly, bloodstream infections, the infections that give rise to sepsis, only in 15% of cases do they involve the bloodstream, okay? And then in a third of cases of sepsis, no source is identified. And these are other common infections that we see in our environment that can predispose to sepsis: necrotizing fasciitis, surgical site infections, infected central lines, cellulitis, diabetic foot ulcer, and ventilator-associated pneumonia. So all of these can give rise to sepsis. Now, what are the risk factors for sepsis? There are some high-risk groups for sepsis. Extremes of age, paramount among these are the extremes of age. So in the elderly and in infants, they are at high risk of sepsis. And then in the immunocompromised individuals, those with neutropenia, they are also at high risk for sepsis. Persons with chronic health conditions such as diabetes, cancer, kidney, and liver disease, and in our hospital environments, those that are with implanted devices or endotracheal tubes, those that have had a prolonged hospital stay, admission in the intensive care units, recent surgery, and even pregnancy. These are all high-risk groups for sepsis. Now, we want to talk about the pathophysiology of sepsis. Because we have a diverse audience, we have all categories of healthcare workers here, we have people from the lay public. I'm going to try to keep it as simple as possible. No mentioning of the gamut of cytokines that are involved. I'll just try and make it as understandable as possible. Suffice to say that in the normal host immune response to any infection, inflammation plays a large part in trying to curtail the infection. In a typical inflammatory reaction, the local pro-inflammatory processes are usually balanced by systemic anti-inflammatory processes, okay? And these automatically terminate the inflammatory process within a short time. That time is enough for the white blood cells or neutrophils to get to the site of infection, and with the cytokines and the chemical mediators of infection, they are able to curtail the infection. That is in a typical inflammatory reaction. However, in sepsis, the cytokine production continues in an unending manner, and you have circulatory spread of the cytokines causing increased cytokines at distant sites. So we can see sepsis as an atypical inflammatory reaction where the pro and inflammatory factors are not in equilibrium. There's no balance. And this is with the pro-inflammatory processes dominating. Okay, and we know that those chemical mediators of inflammation, they can cause a lot of damage, not only to the inciting pathogen, but also to the host tissues. So one of the important products of the pro-inflammatory mechanisms is nitric oxide. So nitric oxide release causes widespread arterial and venous vasodilation. Okay, and this leads to reduced cardiac output and reduced systemic vascular resistance. It also reduces the myocardial contractility. All these together will reduce the mean arterial pressure, and this reduces tissue perfusion to the organs and causes organ dysfunction. The mean arterial pressure is a function of the cardiac output and the systemic vascular resistance, which when both of them are lowered, you have a real reduction in the mean arterial pressure. Of course, this will eventually lead to hypotension, which if not contained, will lead to septic shock. And then another effect of the nitric oxide is that it increases vascular permeability. This will reduce circulating volume, further worsening the hypotension and septic shock. Then something else that happens is that there's increased procoagulant factors, and these will cause small clots in the capillaries, which will further impair blood flow to the tissue. All of these together will lead to the organ dysfunction that is seen in sepsis. Now, what are the clinical features of sepsis? Sepsis is a condition that has really non-specific symptoms, and the presentation varies. Because sepsis coexists with infection, and it's often found with other comorbidities. All of these things, the infections, the comorbidities, they produce their own signs and symptoms. And the challenge in recognizing sepsis is to pick out the signs of sepsis from among the other abnormalities that are plaguing the patient. Okay, so but generally fever, an increased heart rate, that is tachycardia, increased rate of breathing, that's tachypnea, altered mental status, slurred speech, reduced urinary output. These are all common signs and features that we find in patients with sepsis. If you look at this slide, you will find possible differentials for sepsis. So it shows that sepsis is a really non-specific, it has a really non-specific presentation. It can be mimicked by anything from anaphylaxis to cardiac, congestive heart failure, endocrine abnormalities, neurologic problems, pancreatitis, acute respiratory distress syndrome. All of these can coexist with sepsis, or even when they are on their own, mimic sepsis, and that makes sepsis difficult to recognize. So how do we diagnose sepsis with these non-specific presentations? Mostly, sepsis is a clinical diagnosis. And to make sepsis easier to identify, there have been efforts by experts to standardize the definition despite the wide range of presentation. So we've had different definitions of sepsis, right from as far back as 1991. That is known as sepsis 1. Then sepsis 2 was in 2001, and sepsis 3 in 2014. They were trying to standardize the definition of sepsis so that everyone can recognize sepsis. So previously, what was used is what we call the systemic inflammatory response syndrome criteria, or the SARS criteria. But currently, what is advocated is the sequential organ failure assessment score, also known as the SOFA score. And then we have the quick SOFA, which is an abridged or a very simple version of the SOFA score that can help to identify patients with sepsis in a non-critical care environment. Okay, so this slide just tries to show the difference between the sepsis 2 definition of sepsis and sepsis 3. So previously, sepsis was defined in terms of systemic inflammatory response syndrome in the presence of an infection. And from the next slide, we'll discuss what the SARS criteria are. And then there was another category known as severe sepsis, where you have the SARS in the presence of infection together with organ dysfunction. That was classified as severe sepsis. And then finally, shock, when you have refractory hypotension in the presence of sepsis. But the problem with the SARS criteria is very, very non-specific. And you have so many other conditions that could present as SARS. And so in 2016, a new standardized definition was given, eliminating the need for the SARS criteria and then the severe sepsis category. And so sepsis is now defined as infection with the organ failure, okay, as measured by the SOFA score, which we'll discuss in a subsequent slide. And then shock, in addition to refractory hypotension, the presence of hyperlactatemia, which shows the real hypoperfusion metabolic disorder that is going on at the cellular or tissue level, is septic shock. So the SARS criteria, which were previously used, are temperature less than 36 degrees centigrade or greater than 38, a heart rate of 90 beats per minute or more than 20 breaths per minute for the respiratory rates, and then the white cell count, either an elevated count more than 12,000 per millimeter cube, or a very low count less than 4,000, or the presence of immature forms, 10% immature forms. So when you have 2 or more of these criteria, is severe inflammatory response syndrome. And in the presence of confirmed or presumed infection, you can make a diagnosis of sepsis. That was the previous criteria. But now we have moved to the use of sequential organ failure assessment score, or the SOFA score. Now this score assesses several organ systems: the cardiovascular system, the central nervous system, the respiratory system, coagulation, liver, and kidney function. Okay, so these are the 6 systems that are assessed by the SOFA score. And when you have a score of 2 or more in the presence of infection, this indicates sepsis. Or for those individuals that have a background liver or kidney disease or some background problem, when there's a change of 2 or more in the SOFA score, then you can make a diagnosis of sepsis. The SOFA score also is more useful than the SARS criteria because it has predictive value. So the scoring has been shown, that when it's less than 9 points, you have a mortality rate of about 30% or so. But when it's more than 11 points, then you have mortality approaching 90%. So it's predictive and it's very useful, but it's used mostly in critical care setting, like the intensive care units. And also notice that apart from clinical measurements or clinical assessments, you will also have to do some laboratory testing for coagulation, the liver function, and looking at bilirubin, and then kidneys, looking at creatinine. Now, the quick SOFA score was advocated to help in situations where, it's difficult to do some of all those laboratory assessments and things. So the quick SOFA score is recommended for rapid diagnosis in an outpatient setting and emergency hospital admission for patients with suspected infection and sepsis. It's rapid, so it rapidly identifies patients at potential risk of sepsis because it is an indicator of increased risk of clinical deterioration, and it can be performed quickly and repeatedly, and it's easy and does not require laboratory testing. So what it just takes into account is the blood pressure. Blood pressure less than 100 millimeter of mercury is a point. Altered mental status is a point. And then increased respiratory rate, that's tachypnea, greater than 22 breaths per minute, it's a point. A score of 2 or more suggests a greater risk of a poor outcome. And like I said, it can be done repeatedly so that sepsis is quickly recognized or quickly suspected, and other tests can be done. Now, how do we manage sepsis? The guidelines for managing sepsis have undergone a lot of evolution, a lot of changes have been made over the years. But generally, sepsis is treatable if recognized quickly and timely targeted interventions are implemented. The outcomes are improved. So the sepsis management can be broadly divided into 3 things to take and 3 things to give. You need to take blood cultures. Blood cultures ideally should be taken before empirical antibiotics are given. But if there's a delay in getting blood cultures, it should not delay the institution of antibiotics. So within the first hour, antibiotics should have been given once the patient presents and sepsis is suspected. Then serum lactate is very, very important in managing sepsis because it helps you know how the septic process is progressing. And then the urine output should also be measured. So 3 things to take. Then to give, you should give empirical broad spectrum intravenous antibiotics based, of course, on local susceptibility patterns and experience with empiric antibiotics in that locality. And then the fluids are also very important. Crystalloids should be administered 30 mL per kg for hypotension or when the serum lactate is more than 4 millimoles per liter. And then oxygen too is essential. Additional things that can be given include vasopressors. So vasopressors are used when there's refractory hypotension. Then patients should have vasopressors like noradrenaline. And another important thing to consider or to do is source control. Source control takes care of the source of infection. If the source of infection is not controlled, despite everything that is done, the septic process progresses unabated. So if there's an abscess anywhere in the abdomen or in any part, it should be drained. If there's an intravenous catheter that is likely the source of infection, it should be removed. So these are examples of source control. Now, having looked at the diagnosis and management of sepsis, what are the challenges? And you will agree with me that the challenges are gamut. But I've broadly divided the challenges in sepsis diagnosis and management in 3 broad groups. So the first one is inherent in sepsis itself. Difficulties in recognizing sepsis is a challenge, or it's a group of challenges. And then the health systems challenge. This has to do with shortage of resources. Then finally, there's a cognitive challenge or bias. And this has to do with difficulties in recognizing and diagnosing non-bacterial causes of sepsis. Like I said, sepsis is organ dysfunction that is life-threatening across all pathogen groups, but bacterial sepsis is the most common. However, there is this cognitive bias, which we will talk about in subsequent slides. Now, the first group, difficulty in recognizing sepsis. First of all, there's poor awareness of sepsis among healthcare workers and even the lay public. There's poor awareness of sepsis. So things like the World Sepsis Day are trying to correct that poor awareness. However, with sepsis itself, to date, there is no single physiologic change that has been found to be specific and sensitive enough to identify sepsis. A lot of times when we try to manage sepsis or when we suspect sepsis, we rely a lot on blood cultures. And blood culture is the gold standard for diagnosing bloodstream infection. But remember that it's only about 15% of sepsis cases that involve the bloodstream. So that's already a limitation. But blood cultures themselves are also limited by poor sensitivity and the required processing time. So you need a couple of days to up to a week sometimes to get the results of conventional blood cultures. Then we have the challenges in clinical diagnosis, which require and requirement for prompt diagnosis and treatment, which have led to a reliance on biomarkers. Since we cannot, first of all, blood cultures is only in 15% of cases that they would actually be useful. And then we have the required processing time, the sensitivity, and all of that. So we now rely on biomarkers like white blood cell counts, C-reactive protein, and procalcitonin. However, these markers themselves, they lack sensitivity and or specificity. So these are inherent challenges in recognizing sepsis. So when sepsis is not recognized on time, it gets to like a point of no return. The other group of challenges are the health system challenges or resource shortages, especially in the low and middle income countries, of which Nigeria is one. Critical care measures, even though they are beneficial, cannot be implemented in many parts because we have shortage of resources, including the skilled manpower, the complex equipment, ventilators, and all of that, and the drugs that are needed to adequately care for sepsis. A lot of sepsis patients or patients who are down with sepsis are being cared for in the wards because of lack of ICU space, lack of the manpower to take care of them in the critical care units, equipment, and all of that. Lactate measurement, how many of our facilities are measuring lactate? These are all health system challenges. And then even the blood cultures that we rely on so much, their availability, their accessibility, their affordability for efficient blood cultures remains a problem in many, many settings. Quite a number of tertiary institutions have the automated blood cultures, which are recommended now, but they are expensive for patients that pay out of pocket for you to do the required number of blood cultures that can actually give you a high sensitivity to pick the inciting pathogen. And then we have supply chain problems from time to time. We have stockouts and so on and so forth. These are all health system challenges that affect diagnosis and management of sepsis. And then finally, we have cognitive challenges. Okay, so sepsis usually follows bacterial infections. However, it can be caused by other pathogens. In fact, in the height of the COVID-19 pandemic, there was the discussion of whether COVID-19 itself was a cause of sepsis because many of the features were in keeping with the diagnosis of or the definition of sepsis. Another important group of pathogens that I may have some bias here, but fungal infections are also important in the healthcare environment and in certain hosts that are at risk. And these groups can also have fungal sepsis. It's estimated that up to 20% of sepsis could be due to fungal infections. So invasive candidiasis, including candidemia, which is candida in the bloodstream, is an important and common source of sepsis in neonates, patients with central lines, and those that have had abdominal surgeries. They are at high risk for invasive candidiasis. And a lot of times, because of this cognitive bias or this cognitive challenge, it's not quickly realized that these patients could be having a fungal sepsis. Then invasive aspergillosis is also important to be considered in patients that are neutropenic and in patients that are in the intensive care unit being ventilated. These can also cause sepsis in patients. The challenges that we have are the low index of suspicion that is usually had amongst the healthcare workers. And apart from the low index of suspicion, there are challenges in diagnosing invasive fungal infections. The diagnostic procedures that would help to diagnose these infections are not readily practiced. So for instance, invasive aspergillosis, you want to do a bronchoscopy to do, bronchoalveolar lavage to culture for aspergillus, but it's not readily done. It's not something that is readily done. And then even the tools to make effective diagnosis may not be readily available. So with all this gamut of challenges, the consensus is that sepsis diagnosis and management is challenging all over the world, more so in low resource settings. So what we are advocating is that prevention is better than cure, and that is will account for the rest of the presentation and discussion. So on this slide, what we have here is showing the levels of prevention. And we are advocating for sepsis to be taken out of just the clinical context to a public health context, because public health is where you have preventive medicine really going on. And the levels of prevention are primary prevention, secondary prevention, and tertiary prevention. We'll be dwelling most especially on the primary prevention because that is before sepsis takes place. Prevention of infections and the onset of sepsis is what primary prevention is all about. You can see it here. It entails things like immunization, hygiene, public awareness, prophylaxis, management of risk factors, and so on. Then for secondary prevention is actually what we have kind of discussed. We want to detect the onset of sepsis early and treat it early. So we have the sepsis care bundles, awareness amongst providers in the emergency and triage units, and then having sepsis alerts and rapid response teams. These can help to detect sepsis early. For tertiary prevention is limiting the consequences of sepsis when sepsis has already, the onset of sepsis has already taken place. You want to limit the consequences. So patients that have been recognized to have sepsis should have intensive care. But like I've said, it's a problem, it's a challenge. And then rehabilitation, post-ICU clinics. There are cognitive, physical, and psychosocial effects that occur after sepsis that we are not even talking about. We are just talking about whether the patient can even survive sepsis. So these are all taken care of in tertiary prevention. But like I said, we are dwelling more in primary prevention because this is how we prevent infections that will eventually lead to sepsis. So the first one we'll talk about is vaccination. We are very conversant with childhood immunizations that they prevent a lot of childhood killer diseases, which the final common pathway of many of these infections is usually sepsis. But what about vaccination for the elderly? Okay, patients that are 65 years and older. There have been strong advocacy for pneumococcal vaccines in the elderly, but the uptake is low because these patients are at high risk for, or these individuals are at high risk for sepsis. If for any reasons they come down with pneumococcal lower respiratory tract infections, which is quite common in them, they easily tilt to sepsis. So they should be vaccinated so that they don't even have these infections. COVID-19, the elderly were also high risk for severe COVID-19, which can be taken as a form of sepsis. In the Western countries, influenza, elderly patients need to be need to be vaccinated against influenza and even respiratory syncytial virus. But in our own environment, we are not sure what the burden of these infections are. Perhaps there should be more research to find out how many of our elderly patients that come down with respiratory infections have these viral infections that would predispose them to sepsis and would need vaccination to prevent that. And then other groups of patients like splenectomized patients, sickle cell disease patients, these patients, they need to receive vaccination. This will prevent infections in the first place that would finally lead to sepsis. So we've talked about vaccination. These are the other measures. The one measure of primary prevention that I really want to talk about is infection control practices. Very, very important, infection control. Especially in our hospitals, okay? So infection prevention and control, in the hospital environment, up to 10% of infections that occur come from medical equipment, implants, and devices. Then you have cross-contamination from healthcare workers. And just practicing hand hygiene alone can reduce infection rates in the hospitals by up to 50%. And then you have a clean, well-functioning environment and equipment that will further reduce infection rates. Safe water and sanitation will reduce infection rates. So infection prevention and control is a very important way of reducing the chances of a patient coming down with infection that would finally end in sepsis, because the hospital environment is full of debilitated patients, patients that have one condition or the other, and they are at high risk for sepsis. So like I've mentioned, hand hygiene is very important. Effective sterilization and disinfection of medical equipment and instruments. Reductions in the use and duration of indwelling catheters. So if you have patients with urinary catheters that are there longer than they are necessary, these are all routes to sepsis. So we need to have care bundles for these indwelling devices that specify when they should be taken out, how long they should stay, and their care. Then rigorous wound care, including care of surgical site wounds, decubitus ulcers, patients with diabetic foot. These are all avenues through which a patient can develop sepsis. And then transmission-based precautions to prevent the spread of infections in the hospital environment. These will reduce infections and invariably reduce sepsis. Okay, so these are just the 5 moments of hand hygiene before having contact with a patient, before performing an aseptic task on the patient, after body fluid exposure, after patient contact, and after contact with the patient's surroundings. If we can take this into cognizance, we can reduce the incidence of sepsis in our settings by up to 50%. Then antimicrobial prophylaxis, especially surgical prophylaxis before performing surgery. Surgical prophylaxis will reduce the chances of surgical site infections, which will reduce the chances of sepsis. Even in the use of central lines, we have what we call the antibiotic lock, which prevents infection with central line as a source. Then in neutropenic patients that have become immunosuppressed for one reason or the other, they require antibiotic prophylaxis and antifungal prophylaxis. Antifungal prophylaxis, effective antifungal prophylaxis, which should be mold active, because one of the challenges that they have, apart from having maybe candida infection, which fluconazole is the antifungal that is usually used, but it is not mold active. So that would prevent, or rather that would not cover for things like aspergillus, which these patients are at high risk of. So they should have antibiotic prophylaxis and effective antifungal prophylaxis. However, the antimicrobial prophylaxis has its drawbacks. We have the problems of antimicrobial resistance, which is there. But prevention, like I said, is better than cure. Then antimicrobial stewardship. This on face value appears to be like a long shot, but antimicrobial resistance is an important driver of sepsis, especially in healthcare settings. Because what happens is that you've recognized the patient has sepsis, you are treating the patients with antimicrobials, but the antimicrobials are not effective. And so the pathogens go on unabated, and the antimicrobials are not able to eliminate the inciting pathogens. And so that invariably will lead to progression of sepsis. So antimicrobial stewardship practices would in the long run reduce sepsis incidence because the antimicrobials would be effective. And when effective antimicrobials are used in a patient that is recognized early, sepsis is treatable. So antimicrobial stewardship is a preventive measure in the case of sepsis. So secondary prevention, we will not dwell much on this. We've already talked about how to recognize early and treat, but we've talked about the challenges inherent in early recognition of sepsis. Just like myocardial infarction and stroke, sepsis has its golden hours. In fact, over the years, the time in which to institute effective management of sepsis has been reduced over the years. Even now, it's like you must treat this patient within an hour, and that is very, very difficult to achieve, especially in a setting such as ours. Antibiotic treatment is more effective when sepsis is suspected, recognized, and treated early. Like I've already mentioned, this is challenging. Then tertiary prevention, like I said, this refers to the measures that we take to limit the downstream effects of sepsis by optimizing post-sepsis care or the post-sepsis health trajectory. It includes preventing recurrence of sepsis. A number of patients have sepsis and they come out of it and it recurs. And then long-term mortality, long-term morbidity that cuts across psychological, cognitive, and physical function. Tertiary prevention is still in its early phase, even in other parts of the world. It includes things like lung protective ventilation, early awakening and mobility, early nutrition, skincare, early rehabilitation, and so on and so forth. So that's tertiary prevention. So in conclusion, sepsis is treatable. However, like we've discussed, diagnosis and management of sepsis in acute care remains very challenging, especially in low resource settings. So we should place a lot of emphasis on prevention to stop sepsis and save lives. These are my references. So thank you very much for listening. I'll hand over to the moderator, Dr. Iguma. Maybe we'll have some questions and comments. Maybe we should take a comment from, I don't know if the DC Mark is still here.
Okay. Thank you very much, our amiable speaker. He did the presentation and he says her style of presentation was not unexpected. I know that she will go to do a huge justice to this topic, sepsis. Today, we want to, there are a few questions already on the chat box and more questions are still pouring in. However, if you have a comment, questions, we just want people to signify by the way of raise of hands. We'll have over 96 persons on attendance now. But before we continue, some member of our management are on the call. One of our DC mans, Dr. Amina Okaku, is here. Another senior member of the hospital. Please, ma, can you say a word or two to us before we continue with the comments and questions? Thank you, ma.
Good afternoon, all. My name is Amina Okaku. I want to thank the Department of Medical Microbiology for taking time out to celebrate the World Sepsis Day and drawing attention to the need to be proactive in tackling cases of suspected sepsis. So I want to thank the lecturer for a very lucid lecture. In fact, I learned a lot today. I've been taking notes. So I pray that this kind of interactions will continue so that we keep on learning and updating ourselves. Thank you very much, Madam Lecturer and the Department of Medical Microbiology.
Thank you very much, Ma. We are so honored to have you in our midst. Before we continue, the other senior member here, the HOD of Department of Medical Microbiology, Professor Yusuf, is here. So we want you to say a word or two. And also Professor Ioha is here, one of our professors in the department, without which their support this will not have been possible. So I want you guys to say one or two things, sir, before the question and answer continues.
Hello, good afternoon.
Good afternoon, sir.
Yeah, I want to thank you very much for keeping the department bubbling. This is a very topical issue that we have been dealing with for a very long time. So sepsis is one condition that leads to a lot of mortality and morbidity. So it's good that we are part of the awareness campaign to ensure that it's dealt with right on time. So I thank the presenter and the department for a job well done. Thank you.
Thank you very much, sir. So we now switch to question and answer. But before we do that, please, if you have any questions, signify by way of raise of hand.
Dr. Iguma, there's a question that I'm seeing here. To what extent is your department collaborating with clinicians in the fight against this Hydra-headed problem with mortality so high worldwide? So I think I would like to make a comment with regards to that. We received quite a number of consults in the department, and I think I can boldly say that 60%, if not more, of the consults we receive are patients query sepsis. It's always query sepsis. And so what we try to do, we try to assess those patients. One of the important things that we do is to ensure that cultures are taken. But like you said, we have challenges with blood culture, not necessarily a problem of the hospital itself, just a problem of the method of diagnosing infection. There are more modern methods using molecular means to quickly identify pathogens in the bloodstream, but those are not readily available to us. But we try to do our best, and I think we collaborate with clinicians to a large extent, especially in the departments of medicine, then O&G, and generally everyone. ICU a lot in ICU.
Okay, another question is here by Kanta. Sorry if I murdered the name. So what is being done about abuse of antibiotics and use of subnormal doses and fake drug? Well, before the presenter will respond, let me just say a word or two. Of course, this first of all this is a management question. One, because the fight against antimicrobial misuse is a global fight. And for here, in the hospital, not just the Department of Medical Microbiology Committee is doing a lot in this regard, though it's in a rudimentary stage at this point. Awareness is going to be rolled out on this regard to the extent we can do. The presenter emphasized much on the primary prevention, which our focus largely in this regard is going to be with the clinicians, how to use antibiotics optimally. But for fake and suboptimal doses, of course, if it's the dosage, our intervention can be of help. But the suboptimal concentration and fake drugs is beyond what we can do within the hospital. That's where government policy and others an awareness, and will roll out more of this in subsequent times so that our clinician will be well abreast, and all of us will be on the same page when dealing with this.
My question is, what about when blood cultures say negative, but you can see all the signs of sepsis in a patient? Of course, the advice in that case would be to treat. You need to treat a patient that you suspect has sepsis. You also need to be reassessing the patient. You also need to be looking at whether you are dealing with something else besides. Now we have Aspergillus galactomannan in those patients that are at risk. We are in collaboration with a group known as NIFUSCAB, and we have Aspergillus galactomannan, which can be used in neutropenic patients to make a diagnosis of invasive aspergillosis, which can be a cause of sepsis. And then you really need to look for other sources of infection. So you need to keep reassessing the patient, and the sign of the source of the infection may just become apparent, but you need to treat a patient that has the signs of sepsis. I hope that answers the question.
Yeah, it should. But, in the presentation, you said that maybe less than or more, just about 30% of blood culture, even in most civilized places, that will be positive.
Exactly.
So it's not, even if, she said, even if the blood culture is negative, organ dysfunction secondary to host immune response to dysregulated host is playing out. The infection might just be minimal, though management of source of focus is very important. So when the blood culture is negative and you have all the signs and symptoms suggestive of sepsis, is better to just continue management and be assessing, as she said. So more questions are pouring me.
I see one about suggesting a mold-active antifungal. Yes, mold-active antifungals, you have voriconazole. Of course, it's expensive. We have voriconazole. Those are mold-active antifungals.
Now, can you respond to this question, please? I say, thank you, ma'am. The patient had a central line, but later developed infective enterocarditis. The vegetation was seen in the tricuspid valve. The patient was noted to have hepatosplenomegaly. Should antifungal be added to the antibiotic regimen? Which antifungal are sensitive to mold?
Okay, I think I've answered the second part of the question. The first part, vegetations were seen. I didn't get that.
In the tricuspid valve.
Okay, was that through echocardiography or how? Well, I'm not too sure how to handle that case. That will probably need some more deliberation on my part. Who is asking that question? Is it somebody from UBTH that can be answered later?
No. Emmanuel Wu. But for the vegetation, of course, from central line, if it's associated with it, we know that central line is one of the predisposing factors to infective endocarditis. The first thing to do is to remove the central line. And we have seen that from experience in the ICU. Whenever we have cases like that, when you remove vegetation, you are going to manage as such. You know, we said that when you are taking blood culture from infective endocarditis, minimum of 3 sets of blood culture. And of course, you are going to treat for up to 14 days. But adding antifungal, I think the speaker will talk about that.
Well, I'm not sure what the source of the vegetations are. So I think I have a challenge answering that question right now.
Okay, so in SOFA scoring, let's explain the role of hypertension, especially under 2, 3, and 4 vasopressor. Okay. She wants to share the screen again. While she's sharing the screen, we know that the role of hypertension or blood pressure, not hypertension in sepsis. You know, in sepsis is a function of hypotension, not hypertension. So, and the marker there is usually the mean arterial blood pressure. So if it's less than 70, you know that you are in for something. So what you will do is to start fluid resuscitation. So, and you make diagnosis of septic shock also based on reduced mean arterial blood pressure less than 65. So, and despite fluid resuscitation, the mean arterial blood pressure is crashing below 65. Then you institute vasopressor agents. At that point, you are in septic shock. So every aggressive modality you have to put in place to make sure the patient comes back has to be done. So there's question coming in where there are many microbiologists and infectious disease on call. If anywhere you can throw more light on this question so that it will be totally enlightening. I could see Professor Sado on call also. You may want to say 1 or 2 things. Thank you on this. Kindly throw more light on diagnosis as simple as specimen collection among our house officers. That will require orientation.
Maybe they need orientation and training to help in that regard. But that can be arranged on a departmental basis, maybe, or unit basis. I think that can be arranged.
Let me recognize
they definitely need orientation.
My teacher, Professor Dr. Awukpeju. You are here. Thank you very much, ma, for joining us. Professor Olowo, thank you very much, sir, for joining us, for your fatherly support. So in the absence of more questions, I think questions or contributions, let's, okay. So I'm waiting for 1 or 2 good messages from our seniors to say, Professor Olowo, will you want to say 1 or 2 things to us, sir? Okay, in the absence of any contribution question, I want to say special thank you to everybody that joined. We had up to 97 participants in this commemoration of this World Sepsis Days. We hope to do better subsequently, and maybe next year it could just be a physical meeting. So thank you very much. Once again, I want to say thank you to the management of University of Benin Teaching Hospital for giving us this platform, and the member of management. Our CMD is always supporting innovation. So, and special thanks to the ICT team of the hospital. I will not fail to say thank you to our photographer that gave us a beautiful photograph, and our focal person in the ICT, Mr. Elo, the HOD of the ICT, Ms. Ebere, who did wonderful work for us. I want to say special thank you to you all. for the good work you did for us. I can see Professor Oluedo here. Thank you very much, ma, for coming through for us. Thank you very much, ma. Thank you very much, ma. We are grateful, ma. Dr. Mrs. Sakba, thank you very much for all the assistance, the support you guys give to us for this. All that participated, I may not be able to recognize everybody. You say thank you very much. So we are saying thank you for coming. So in the absence of any other questions and comments, I want to bring this meeting to a close. Thank you. September 13, 2024, we'll do it again in a bigger way. Thank you very much, everybody.